All right, Dr. Morris, Dr. Fuster, we have our last community relations talk, otherwise known as our doc talk. And Dr. Fuster, you are a special guest today. Dr. Morris, love to see you. Dr. Fuster, tell us what you're going to be talking about today.
Great. Thank you so much, Tony. Thanks, Dr. Morris, and thank you to the ALA for supporting ongoing community talks like this. This is great. I'm going to be talking about advances in the diagnosis and evaluation of lung cancer, because that's incredibly important for treatment. And it's basically what a patient would go through in terms of concerns or the actual diagnosis of lung cancer, kind of extending from what Dr. Monarchion talked about last week on screening. And this is a great time to talk about this. It's the turquoise takeover period. So we love crushing lung cancer and talking all about it and figuring out what we can do and show you advances and the latest, greatest in technology and in the thinking of how to do the best care for lung cancer based on diagnosis.
And Tony, Mark's such a great person to talk about this. He's really one of the smartest guys I know, and a world expert in the diagnosis and treatment of lung cancer. And he's got a lot of great news, good news for people who are going through this process, and it's really come a long way over recent years.
Well, I'm looking forward to this conversation. Let's not waste any more time. Let's get right into it.
Thank you. Great.
Well, thank you, guys. That was a great introduction. Hello, everyone. Welcome. My name is Tim Morris, and I am the chair of the American Lung Association Mission Committee. And the Mission Committee is composed of a lot of eclectic healthcare workers and people in other related fields who have banded together to help the Lung Association accomplish its mission of improving the lung health of the general community, and especially us here in San Diego. One of our exercises is to perform these community connections series, or dinners with the docs. And we've been doing this now for 3 seasons. This is the final episode in our last season. Many thanks to the Burr Heart and Lung Clinic at Sharp Grossmont Hospital and the San Diego Foundation for sponsoring this series. It's been a great series. If you missed any of them, they're all available on YouTube, and there's a link on the American Lung Association website to get you there. But for our final talk, in line with the turquoise takeover, you notice my turquoise tie here, which is all about the prevention, detection, and treatment of lung cancer. We have a special treat of Mark Fuster, who is an expert in the clinical management of lung cancer, and actually a very, very productive scientist in the fields of basic biology regarding the control of lung cancer. So Mark's going to talk with us about lung cancer detection and evaluation. And then, as always, we'll have a little panel discussion at the end to sort of pick his brain. So Mark, welcome.
Great. Can you hear me okay? Thank you so much, Tim.
Yeah.
I appreciate it. Thank you for that intro, and it's a very kind introduction. I'm going to just share my screen right now. Let's see if I can get that going here. All right. And there we are. Can you see my screen okay now?
Yeah, we can see it.
Perfect. Yeah, so thank you very much. I thank the ALA for this great opportunity. I thank the ALA for supporting research in lung cancer and lung disease in general. Thank you, Tony Gwynn, for this great opportunity as well, and for everybody that's working hard to fight lung disease. And lung cancer is, I think, as you well put it, it's kind of one of the last in this series of discussions that we're having. The last couple of times here, we had Dr. Monarchion last week that talked about lung cancer screening. And here, another round of dinner with a doc. I'm happy to guest gather around dinner and chat, just kind of informally, but with some hopefully good pictorials of advances that we're trying to make and making in lung cancer detection or diagnosis and evaluation. And really the sort of AKA, or also known as in this talk, is really, it's a talk about, just try to control my screen here. There we go. I've got a nodule. Is it lung cancer? And have we caught it in time? Those are really the kind of key sort of filtered questions that sort of are the main gist here. Is, you know, sort of like now somebody caught a nodule, maybe it was through a screen and maybe through some other ways I'm going to share. Now what? And what can be done? And if it looks like lung cancer, what can we do to do the best care? And in addition, what technologies do we have to make the diagnosis and the treatment the most accurate and the safest and the most effective possible? So you can't really give a talk like this without starting with the ways in which the process of lung cancer detection and evaluation is really inextricably linked to prevention. And that's the best thing you can do, is prevent altogether. The no-brainer is sort of put in red there as the leading cause of lung cancer death, leading cause of lung cancer incidence is tobacco and cigarette use. We're seeing new data and other combustion products, new questions on vaping. We've been talking about lots of other risks that come in around tobacco, even secondhand smoke, but the big elephant in the room is tobacco smoke. The other type of risks that come with alongside it, sometimes synergistically work with tobacco, and there are also risks that by themselves have impart a lung cancer risk to individuals in various occupations. Might be asbestos, that's a big one. Usually occupational. I've kind of put a list here on this slide of occupational exposures through other types of substances, chemicals, hydrocarbons, people that work with radiation. Radon, there's some in the ground irradiation, certain areas where you build your home if you have a high risk in the family of lung cancer, such as genetic factors, that's a family risk. It might be worth checking into the residential area you're in that there isn't high radon exposure. Indoor cooking fumes worldwide, this is actually a big problem. It's not just smoking, but just the release of hydrocarbons and burned products into the unventilated air. Pollution could be included there, and lung scarring, fibrosis, and inflammation, and just some pictorials. There's asbestos fibers. There's some sort of dangers for the types of things I've been talking about. Genetics, your own genetics, family history can contribute. Some things you just can't control as well. And then having lung disease. And these are probably the biggest ones, but again, in red, the elephant in the room is smoking. And when we have our mind to it, diagnosis, detection, evaluation, it's good to kind of think of how these products in the environment can interact with a host, particularly in the lung of the host, to create a field at risk in the lung. And there's usually an area of cells that, these are the basic working units of the lung, the cells that are doing their normal job, but unfortunately, due to these bad irritants and drivers of transformation, that's the process of tumor development, of getting a cancer, can lead to that event. And eventually, a cell can take off and grow into a tumor. And that tumor eventually becomes, in a way, a certain size, even a pretty small size. It starts interacting with the host, with your own blood vessels, with your own immune cells. And there's a lot of fascination in how we can help that killing of the tumor by your own body do better. But it also goes the other way, and the tumor does a lot of damage. And even at a pretty small size, lung cancer spreads and causes damage and mortality. And so the whole goal here is to talk about, and my point today is, can we detect this early? How early? Because that can have a strong bearing on outcome, extremely strong bearing. And even as early as when it's, even just the size of a pea, and even then it's at risk of spreading due to the aggression of lung cancer. I should say, take this moment to just also say, once again, you can't have a talk like this without mentioning how incredibly serious lung cancer risk and mortality is. Lung cancer is a leading cause of cancer death in the US and the world. The deaths caused by lung cancer, I think Dr. Monarchion showed it pretty well in a slide last week, if I remember, that the combined mortality from lung cancer exceeds that from a combination of colon cancer, breast cancer, and prostate cancer. So it's really a heavy killer. And again, I can't stress the importance of tobacco cessation as one of the biggest drives that we can try to control in terms of preventing it altogether. Typically, lung cancer is discovered, and this is about detection, this talk. So one of the scariest ways and most concerning ways that we might discover or detect the first footprints of lung cancer, unfortunately, all too common, are a symptom-driven search, or signs and symptoms that are heralding ones, as we call, sort of making the noise to show that something's wrong in the body. And often these kind of things are when lung cancer is already grown enough to be metastatic, or too late to cure, or more difficult to cure. So cough, including coughing up of blood, shortness of breath, chest pain, signs of metastasis. There's a nice pictorial here just showing all the possible ways that lung cancer could cause symptoms. And again, all of these kinds of things, including some of these more common ones I've put in red, in terms of the way it presents: hacking, cough, bleeding, shortness of breath, weight loss, along with signs of metastasis to the brain, for example, headaches or to bones. These are really, even when they're just in the thorax, the tumor is in the chest, the tumor is big enough to be at a point where it probably has spread further than that one point where it's causing bleeding or cough. So we don't like to see this, and unfortunately this is how lung cancer presents all too often. If I sort of put that in sort of a gray background and think of the other ways that lung cancer does what it does, an incidentally found lung nodule might happen during a chest x-ray for whatever reason, a cough for a different reason, or a preoperative going in for an operation or something in the hospital, a chest x-ray for whatever other reason. There's many reasons people get it. Might pick up an incidental spot in the lung, or a CT scan done for another reason. So these are incidental nodules, and they can pick up a round thing or a spot, and that might be an early tumor, an early lung cancer that we can do something about. And by luck, perhaps we've caught it early. Unfortunately, the grayed out ones I just talked about are all too common. But what has come on the scene in the last 10, 15 years that we're sort of been developing, and now we're making a lot more noise about, and we're getting more access to, but it's got a ways to go, is lung cancer screening. So this is actually having a certain amount of risk to a patient due to smoking, due to factors that have to do with age, or concerns that have to do with a certain range of risk, particularly tobacco, and sometimes other factors, and filtering it into a risk where it prompts a CT scan that's done with a low dose to prevent any effects of the radiation, but super sensitive to pick up nodules, to pick up a small nodule early in an at-risk person. So that was talked about very well, I believe, last week by Dr. Montgrain. So I won't spend a lot of time there, but it'll come up in a couple of ways as I go here. And so, I've got a spot in the lung, now what? Here's a chest x-ray. So again, this is not the most sensitive way to pick up lung nodules, and it's not a great way to screen. We've learned early in the course that just doing x-rays for screening does not pick up nodules any better, or have an effect on lung cancer than not doing chest x-rays, versus CT scans that are a different thing. When done for screening, can make a difference. But here, as an incidental on a chest x-ray, you happen to notice this spot, and this is just point out the structures in the chest here. The lungs are dark because there's air. There's the ribs, there's the clavicles and the chest wall and the diaphragms, and the heart's in the middle with the great vessels, and there's airways branching out here, and that's a spot that's abnormal. You can see that even though there's some differences in kind of in shadowing attenuation from the tissues, you still get this kind of standout thing here. And often this leads to kind of the next step of getting a CT scan. And that would show, again, this is the way it looks as the patient's lying on the table here. And it's really essentially a stack of images. So it's a spinning X-ray tube, and it gives a lot more information. So you're sort of stacking cross sections through the chest. This would be the heart here, kind of cut at this level where the arrow is, and showing that nodule. And there it is, standing out very clearly now. And all these little spots are just airways and blood vessels that normally branch out. So when you spin this in 3 dimensions, you can clearly see the running of normal vessels and airways. But this spot will stand out here. And as we get more concerned about this, want to work it up, we learn a lot more about the nodule, whether it's spread in the chest. We learn about lymph nodes in the chest. We learn a lot more information in a CT scan. So for cancer, when you get an abnormality, the sensitivity for cancer and the specificity go way up. And that's why CT scans in low dose screening are important. I'll come back to that again. And we have, when we're worried about this pretty good sized spot, this is probably more than an inch in diameter or a couple centimeters, and the chances of lung cancer go up with the size of the nodule. The fact that it's kind of alone here and has these little spicules and looks abnormal looks very concerning for a cancer. So often with that, we can go to the sort of a more specialized study that doesn't have to be done for all nodules, but when we're worried, this can help us. It's called a PET, or a PET CT scan. It stands for positron emission tomography, which is kind of slices through the body here. It does the same thing. You get a CAT scan, like you see here. This is a different lesion, a different patient, different nodule, and there's the nodule. But what it actually is picking up here is this black spot you can see is the way that nodule stands out on PET. And what is done is this patient's injected with a sugar that's radio labeled with a very safe amount of radioactivity. I do these all the time. It's a very safe technology. But tumors eat up that sugar that's labeled very avidly. And so a tumor will stand out like a sore thumb there, and it can look very bright like that on the fused kind of glowing images that we can make too. So a lot of technology can reconstruct this to show how the abnormality stands out there. And this is, a great move in technology from even a CAT scan, especially when you're worried. But when to use this takes thinking, and it takes some decision making. Because it does expose the body to some more radiation than a CAT scan. So it's about 5-fold roughly more of radiation than a CAT scan, but it's for the still a safe level of radiation when you weigh against what you're trying to do to cure a tumor when something looks abnormal, or when the risk of lung cancer seems much higher. So there again, in this sort of movement from a CT scan to this kind of a scan, the sensitivity and specificity for cancer move up even more sensitive, more specific, just given the way that this heat can pick it up and give some specificity. But I'll put a word of caution that other things can light up, even infections, even inflammatory diseases like rheumatoid disease or other things. Rheumatoid arthritis with nodules in the lung can occur. Conditions like sarcoidosis that cause hot lymph nodes to light up. And on this technology, lots of infections can do this. So we have to filter all that clinically and look at the picture and see that this is really behaving like a cancer. Back to low-dose CT scanning, we might actually move to a PET scan like that when we have a nodule that is still relatively small. And that's what low-dose CT scans can do, is you're putting in a step back. You haven't picked up something that's scary by symptoms, and usually you're just picking this up through the intended high-risk patient that you've screened with a low dose of radiation to get this unique scan that can show us a hopefully smaller spot. And this kind of a spot can, in some patients, be big enough and might have even spread to the lymph nodes that I'll show you in a moment the importance of. But that's a situation where the PET scan can be useful to even work this scan up further and help us think about, is this lung cancer or not? And so this is typically done for nowadays, if we've sort of moved onward with recommendations. Again, Dr. Monarchion talked about this quite a bit last week, but patients that are in this age range of 50 to 80 with about 20 pack year exposure, that's a certain dose of cigarettes over, a pack a day for 20 years or 2 packs a day for 10 years. And that kind of level of smoking, and having done it within the last 15 years, is where now it's a solid recommendation to use this as a screening technology. So that's a great place to start. And if we do this more often, we found that this technology can push us to do detection of cancer and find it at an earlier stage and intervene earlier and improve our outcomes because we're detecting and curing it earlier. So what about backing up a step, that we're not talking so much cancer, but just to think of all things that can give a pulmonary nodule. This is what in the medical world we call the solitary pulmonary nodule. We picked up a nodule in the lung, and kind of now what? It's here's a close-up on a chest X-ray, and it might show it looks like an ugly spot there. It's got some little white flecks in it. This is some calcium deposits. Sometimes that's a sign that it can be benign, that makes you feel a little better about it. Maybe it's an infection or inflammation from some chronic type of inflammation caused by infections. Sometimes these are called granulomas. It could still be a cancer. And so there's lots of nuances to the actual imaging on just even an X-ray moving over to a CT scan. And that's what we often will do as a CT scan to look at this thing better. And it will guide our next steps for trying to get a diagnosis if we're worried. This can be chronic fungal infections. It could be tuberculosis. It could be a number of things that look like lung cancer. And these things are very common at a small size. So lots of people get small, what are called granulomas, little infections from exposure to chronic fungal infections or things in the environment that don't really move you to very big nodules and stay stable on imaging. And that's the key. And I'll talk about that in kind of the next little part of this slide. But just to keep our wide open mind about being cautious about cancer, this could still be lung cancer. Sometimes the little spicules and the lack of these calcium deposits can look like lung cancer. This could be metastasis from another tumor, particularly if it's round and doesn't have some of the characteristics shown in this more benign looking one here. What are the main risks on any scan, an X-ray or a chest X-ray or a CT scan are that make us worry about lung cancer are not just smoking and increasing age, but the sheer size of the nodule. Nodules that are from 1 to 3 centimeters in size, or bigger than an inch or two, are much more concerning than nodules that are less than a centimeter in size. And we get lots of what we call sub-centimeter nodules that we can just track with serial low-dose scans, especially in a screening program where the vast majority of what we call false positives, things that worried us but are not cancer, can be filtered out with a serial scan. Or there's benign characteristics. Here's a re-windowed just CT scan. So those are the trachea in the middle, big blood vessels. There's the right lung, the left lung. Patient's feet are coming at you, the head's into the page. And so it's a cross section. And this is a nodule, but it's densely calcified. So there's imaging attenuation characteristics that we can tell this is calcium, and we don't have to do more for this. It's when it's uniformly calcified, it's another sort of CT characteristic that helps us to tell that something's benign. Here's a more common small nodule, very small with the yellow arrow pointing at it. And this might be picked up in a screen, it might be incidental. And we have algorithms for following this at a certain rate, depending on size and risks, to help us feel that it's benign and not have to go in there digging with a needle or a bronchoscope or the things I'm going to talk about to look for a diagnosis of cancer in something like this. Although it still could be a cancer, that's why we serially monitor it and need close follow-up. So let's go back to that scarier kind of lesion or nodule with that PET scan that I showed you earlier. And this would be a hot spot looking like a cancer. We often use something called risk calculation. There's calculators where we put in age, smoking status, the size of the nodule, even how much heat it has by units of heat that they use in PET scans, to put it all into an algorithm. And if it falls into a higher risk, we might have to make some decisions as to what to do next. And I'll tell you why. Often in a tumor board, we have a group of experts that meet together. When we know it's cancer, this is a standard of care. But when we're not sure, it's also very healthy to bring these kinds of concerning nodules to the board, where there's radiologists, pulmonologists, oncologists, radiation oncologists, the sort of reading of it and the story of the patient has gone through and go through it with the group. And it's really important to have as a group discussion to help us make the right decision, because more minds that have expertise are better than one. And that's a standard of care for cancer. But here's a kind of a risk spectrum of anything you might pick up like this. And kind of more red and more concerning might be this sort of gradient of risk. And where we can put, for example, a small nodule into a risk calculator, something like this nodule, that if it was cold on the PET scan, if it was not hot like this, could be one of these granulomas, or if it's relatively small nodule size, it might give us a pretty low threshold to just keep observing and do serial scanning rather than doing an intervention, which if we just keep watching this hot thing, it could be very scary as a cancer that we can't give much time for. We usually want to do something within a month or two, so or even weeks if we can. So that in this case, in this particular one where it's a hot nodule or it has certain CT characteristics that make you worry about cancer, we even have a sort of a surgery threshold on the other end where it may make sense to not put the patient through a lot of procedures. And many of those procedures either give you cancer in this setting, or you don't pick it up because they're only so sensitive, and you would be going after this anyway. And so surgery can be the case for some very high risk nodules if you put them in a calculator, or even just hearing large and elderly and bad characteristics and hot on PET, you don't even need a calculator. But there's a sort of a world in the middle that is what we call the indeterminate or intermediate world, where perhaps the diagnostic PET procedure did help us in risk with or without a biopsy. And this might be a CT scan guided biopsy, where if the nodule was kind of on the outside of or near the edge of the chest, we might put and I'll show you pictures of this, a needle to diagnose it from the outside, or even a bronchoscope to get it from the inside. There's also new biomarkers that can help us sort of get a blood test to help us feel that are becoming more integrated in the process to make us feel more confident that if it's, say, cold on the PET scan and the biomarker says, things are low risk here, we can kind of push this threshold over a little bit to keep the serial scanning rather than having to do a biopsy. And so those are a lot of technology that's moving forward and promising, and lots of studies going on to help us improve our detection ability using that algorithm. Here's a CAT scan, since you've seen a couple now, with the cross section shown here. This again, the patient's feet are at you, the head's into the page. And this looks pretty scary. You can see a giant spot. This is almost with full certainty a lung cancer that is invading the airway and into the lung here. It's quite large. It's at least a few inches in size. And this kind of thing is something where approaching it and getting a diagnosis is really important, and getting a stage is important, because just going in to take it out, taking the surgical approach, may be the wrong decision. You may be doing more harm than good, because this might be not only tricky to take it all out, but might be spread already to a lot of lymph nodes in the chest where we're not making a difference by doing surgery. So staging is very important in this whole process regardless. But here's an example where something called bronchoscopy, where we put a bronchoscope down the airways, and here's the right main stem bronchus, that's the left main stem. They've already split. There was a trachea kind of higher up, and these are great vessels, the aorta, pulmonary arteries, and this is kind of the middle of the chest, and we can pass a bronchoscope down and get a tissue sample and do some diagnostic testing of what kind of tumor this is. It's a chance it might not be lung cancer, it could be a lymphoma, it could be another kind of tumor, but the way it looks here, it looks very high risk for lung cancer. And so the bronchoscopy is a very common procedure we will use to diagnose abnormalities in the lung, but in this particular one, it helps us get tissue from this and figure out what kind of cancer it is. And here's some pictorials to show how we can put forceps out through the bronchoscope. This is done with the patient asleep under anesthesia, where we can really control everything going on with a quiet airway and without coughing. And the patient doesn't feel much of anything in this process either, because there's not much nerves to any of this. And the inside of the lung, there aren't many pain fibers. The edges of the lung kind of do, but the patient's fully anesthetized as well. So it makes it a very controlled process to be able to go in, and if the tumor were here in passing down this right airway, let's say, can get a sample. You can pass out needles. Those are very helpful for getting more sampling. And we're usually doing that to not only get the tissue diagnosis, but learn a lot about the host response, what kind of immune cells are there. This patient might be more spread in their tumor. It might be amenable to immunotherapy and forms of treatment that involve combination therapy or targeted therapies. All this is needed to get tissue to learn of those markers in the laboratory. And we can wash for cells as well. And so that's a technique we will use commonly in more central tumors, like this one that I just showed you. But what if the nodule, or the seriously concerning nodule, this could be a PET hot, very peripheral nodule, is way on the edge there? What traditionally has been done, and we still do a lot, is going in, numbing the chest here, and going in with a needle to actually sample a fine needle, usually less than a quarter of the diameter of a pencil, very, very fine needle, but it's very, it can also give tissue and give information about the tumor when we send that to the laboratory. Here's some more pictures of how that might work, and this is called Transthoracic needle aspiration. It traditionally has been more likely to yield an answer when the nodule is a little further out than a bronchoscopy, because the bronchoscope typically can't reach that far out. And so here's a picture of the patient that would be numbed up by the interventional radiologist with a real-time CAT scan, helping to pass a needle into the nodule. And the yield is actually quite good with this technique. It's for nodules that are, a couple, 1 to 2 inches in size, or 1 to 3 centimeters. Those yields are 70, 80, 90% plus, particularly for these peripheral nodules. When the nodules get to less than a centimeter, but they're still concerning due to, and there's a lot of these due to the PET scan, or due to the characteristics of the nodule looking like cancer, it might have funny spiculations or things we really worried about on a CAT scan, then this might often might be a lot harder for them to detect, the interventional radiologist, and using this technique. And so we start, to have to make decisions of whether we're going to go into it with surgery or do serial monitoring if it doesn't look as scary, with serial scanning. So all those kind of decisions come into play as I sort of showed you that risk calculator, and we typically will make as a group and as a shared decision with the patient on the urgency and the detection abilities that we have. And the biggest, I would say, downside to this kind of a procedure is that the rate of popping the lung, if actually a needle going in through the outside of the lung and getting air around that lung, is moderately high, 15 up to 25% for any kind of air around it, but not necessarily causing problems. That can just be air that gets resorbed with a small, what's called pneumothorax, or air around the lung. But a fraction of these, it's not that small, might be as many as, depending on the depth and where this nodule is, anywhere from 1 to 5% of the time can need a chest tube and be in the hospital and help they might have to put a chest tube in around the lung, and they can do that and have to re-expand the lung. And that can be quite morbid in people that have lung disease as well. So bleeding can also occur in a few percent of the cases. So it's definitely got its risks, and it can be quite challenging for small nodules. So kind of back to the question of, if it all gets done either from the inside or the outside, and you're getting tissue, what is the kind of studies that we're looking at? And one of the biggest things we're trying to do is distinguish, and these are now what are called histology. This is actually the cells. These are very microscopic. This whole picture might be just a millimeter across all the way across. So this is through a microscope, and these tiny cells have very unique staining, very unique characteristics. Small cell lung cancer is one kind of lung cancer that's very deadly and tends to spread very easily. If we can catch it earlier, it's great, but it's treated very differently from the other kinds of lung cancer when we can get tissue in by any of these modalities, such as squamous cell lung cancer or adenocarcinoma, or just plain undifferentiated non-small cell lung cancer. And all of these have the ability, particularly these guys on the right, to spread through the bloodstream pretty much almost aggressively as small cell, but they're treated pretty differently. Sometimes we can do a lot of extra tests on the immune patterns, on molecular testing to test for targeted therapies that are expressed more often, certain markers that we can use, personalized therapies with unique drugs that are not necessarily this big time chemo that has a lot more side effects, to have very effective responses by these kinds of tumors, as opposed to, say, squamous cell cancer. So in terms of helping us with markers, with molecular testing, with all the things we do downstream with that little piece of tissue, this is very, very important. Tissue is really an issue, and we don't need very much, but in the pathology suite, that gets run for very important things to help us do the next steps in treatment. I can go a lot more into that part, but that's the treatment of lung cancer. I'm really talking about the first steps to help that treatment, which are detection and trying to detect early. And speaking of early, here's a nice little pictorial of just taking all lung cancer and how it presents. And it's better to show with a picture here. Here's a picture of a kind of a cartoon close-up of the trachea and the branching airways. And this would be out in the lung, this white here. Here's some blood vessels. And there's the esophagus in the back here. And so you're kind of looking straight on at a really close shot of the airways. And I drew in a tumor here, actually put it in the right lower lung. So this is the patient looking at you. And this might be a tumor living in this sort of kind of far out in the airway here and causing all kinds of badness. And if we think of this picture, I can point to it with these kind of different presentations of lung cancer, that only about 15% of the time is the cancer really localized without any spread to these lymph nodes, which are really dangerous things for spread to, because that greatly, as soon as it starts to spread to lymph nodes, that's a much higher chance that the mortality is higher and the chances for cure fall off significantly. Regional lymph nodes, or regional spread, meaning the tumor kind of grows a little more than a tiny nodule, or spreads to lymph nodes that start to track up to more in the middle of the chest, about 22% of the time. And in fact, this combined maybe 1/3 of the time, 30 something percent of lung cancer, if you're lucky to be in that group, it's still only about 55% 5-year survival, where all lung cancer is only about 20% 5-year survival. And the reason for that is that most cancer, as I said in the beginning, we detect when it's too late. And so almost 60% of lung cancers, when you take all comers, are detected where you have the horse that's been out of the barn already. It's spread already. It's I shouldn't say too late, but it's late and harder to treat because now we have new therapies for stage 4 lung cancer. but the survival is still very, very poor when you're out in that realm. And so it's improving, but it's still less than 10, maybe 15%. And so really the name of the game is early. And if you're very lucky to be in this 15% where it's very localized, we can take that out with surgery. Or if you have bad lungs, we can shoot it with radiation. And you can have very good control, if not a cure, with a much higher chance than 54%, maybe as much as 70% plus and up to 90% when the tumor is small. So that's kind of a good overview of why it's so important to stage lung cancer and learn about these lymph nodes and learn about the tumor. And so when we really are worried about lung cancer and we're taking that algorithm of diagnostic steps and we present a patient in a tumor board, we might have some of that PET information, that PET scan to help us show that this is, really a hot lesion. There might be a couple of lymph nodes that were kind of glowing, and even before the tumor board, we might want to get tissue from these lymph nodes because it's really important to stage it to learn if these lymph nodes are involved. It makes a big difference in treatment. One of the ways we have a technology we have for that is an endobrochial ultrasound. So this kind of fuzzy picture here is actually putting a probe that creates ultrasound against the wall of the trachea and against the wall of the airway. And this little bean thing is a lymph node. It actually looks a lot better in real time when you see blood vessels all around it. You can put this needle out, this fine needle, again, patient asleep, no pain, suck out the cells from the lymph node if it looks concerning, and we could stage in and even diagnose lung cancer just with one of these lymph nodes without going all the way out to the tumor. In some cases, we do have to go out to the tumor, and when it's a little further out, you can't just grab it like that earlier picture. We have to have an ultrasound on, and you can see this is more of what we call a radial probe. It's a different kind of ultrasound that comes through the bronchoscope, and it kind of shoots its rays out like the sun from the center, and it can pick up. This is kind of a characteristic tumor look when it has this sort of uniform center with the fuzzies on the outside. And in real time, our expert interventional pulmonologists can use this to help them have confidence that they can put a needle out in it and get tissue from the tumor with that same mind of tissue as the issue. And here's just a little pictorial of like imagining it through the airway, and there's our same tumor ball right here, putting a needle into it with this guided first radial ultrasound to see it, and then we'll take it out and put a new probe with a needle to know we're there and get tissue. So this has gone further, and now just by way of some newer techniques, just to show how we're making advancements, there's something called electromagnetic navigation bronchoscopy. So believe it or not, we can actually, in the last 10 years or so, there's been the development of where we can try to reach nodules that are much further out from the inside, and thereby reducing that pneumothorax or that air around the lung kind of risk. And so it's pretty cool technology. There's little sensors for electromagnetic waves that are created that interact with the tip of the bronchoscope. And in a CAT scan that's been done and kind of reconstructed into a virtual image. So this doesn't have to be real. This is a trachea looking down the airways, and here's the bronchoscopist with a bronchoscope. And there's information from the previous CT scan to guide to even a very peripheral nodule with this sort of follow the purple line, and it sort of guides all the way down to the nodule in real time using these electromagnetic sensors, much like a GPS for a vehicle would tell the vehicle which way to steer to get to a certain location. Well, that's exactly what the technology used here, that we can drive the end of a sampling port or catheter that goes through the bronchoscope all the way out to that region and help to pass very accurately a needle into the area to get a much more peripheral lesion without getting that pneumothorax risk. And there's some latest data from the Navigate study that the current 2-year results show that this has an accuracy. What accuracy means is it gave me a diagnosis either of lung cancer or inflammation or infection of about 70%. That's really not bad. If we're still worried and we don't get an answer, this might take a surgical excision to go at it. But when it is lung cancer, this has the ability to pick up early stage lung cancer, where we can do much more about cancer. About 65% of the time, or of about 60% of lung cancers, it does pick up. So that's much better than that flip side of like 60 or 70% late stage cancer. If we see nodules like this, we can try to drive and detect it early. If we're going to do this, take the approach of doing a biopsy, and done much more safely this way than through the chest wall. And believe it or not, this actually, for even small lesions smaller than a centimeter, it's actually rivaling the technology for a transthoracic needle aspiration. So just in terms of its efficacy. The complication rate's very low, less than 2%. And so that's why this is such attractive technology that's been advancing. And we have a lot of use in our San Diego community. We at UCSD and the VA use this, Sharp, Scripps, it's all over town. Lots of interventional pulmonologists are using it. By way of full disclosure, myself, I'm a pulmonologist, pulmonary and critical care expert, but I'm not an interventional pulmonologist. I have friends, and they're in our system. They're our own pulmonary team that are interventional pulmonologists that help us run this kind of technology. And in fact, the latest, greatest has even advanced further. So there's actually novel bronchoscope catheters that can be passed out that actually, with that pre-constructed CT scan to make a virtual image of the airways, have sensors at the end of this sort of catheter that goes out that it can be just literally driven by its shape sensing of the airways. And that's what's called robotic navigation bronchoscopy. So you'll navigate out there with like a joystick and a wheel. You can sort of rotate and move forward and back with the combination. And the interventional pulmonologist will drive the bronchoscope out and then drive with this robotic holder here and all the technology of shape sensing that's built into the flexible and quite small catheter. This is like 3 millimeters wide, and even smaller things like the flexible needle that can pass through, or less than even less than that. So it's really small catheters that can go out with small gauge needles, but big enough to get tissue and go very far out in the lung. It can be planned beforehand with a CT scan reconstruction of the path to take all the way out to the nodule. And then in real time, you just control it with this super cool joystick technology or wheel and guide technology to go out to the lesion in real time, much like is shown in this picture with the patient there, and the live running of the catheter out with the airways and the CT scan as well reconstructed. And then the actual biopsy, it's pretty cool because you can just park in that position with the patient fully anesthetized and park your catheter showing the tumor out here with the airways branching, and go with very high accuracy with forceps, needles, what have you. Usually a needle is what we do when we get quite far out to give you those tissue samples. And what's quite neat is this is another picture of robotic navigation showing a tumor and showing the pleura, or the lining of the lung, reconstructed. And you can even sort of pre-trim what you want to go after so it's safe and doesn't hit near that pleura, and keep it very safe to get your tumor tissue with all these different views from different angles of the CAT scan. So it's very enticing in that way. And this technology, I believe, has even higher accuracy. Usually people are having experiences of 60 or 100 patients in their own practices and getting higher accuracy than that electromagnetic navigation technique I showed you. And so we're running a lot more of this now. It's pretty hot in town. Monarchion, they're companies that make this. Many use these technologies to safely and accurately get out at much further nodules that are much further out. This is a couple of our fellows in our VA with Dr. Nobari going after one of these. And I was really impressed at how we just kind of trimmed the tumor to safely get in this tumor that was pretty far out and still had risk of, popping the lung from the inside, and got great tissue from this approach and safely. And I guess I would just say, with this hot area, just one or two more thoughts I just wanted to inject at the end here, because this is kind of the latest, greatest, is these transthoracic needle aspirations for 1 centimeter or less nodules. There's a track record of decent, maybe 60% or more yield sometimes if they're in the right place. But it's this kind of technology that we've built up. We can get things from the inside without that risk at a level that rivals these lesions in the outer 1/3 of the lung, and that are less than half an inch, and with great safety. So instead of taking this approach with even sometimes an airway that we can track out to it, this is a little bit of a bigger one. Again, we're using the navigation approach to get out from the inside. In fact, there's a Veritas study that one of our interventional pulmonologists, Dr. Cheng, who runs our program, with a few of others of our interventional pulmonologists and the whole team, is a member of one of 4 centers that are enrolling. It's run out of Vanderbilt, and this one is comparing head-to-head, going after 1 to 3 centimeter nodules in the outer third of the lung with this technology, the navigation technology that's particularly robotic, the type I last showed you, and versus transthoracic needle aspiration. So it's quite exciting. There's some newer CT scans for real-time biopsy accuracy, so you can not even use the one from a week ago or a month ago, or a couple of weeks ago that's reconstructed, but just in real time with a CAT scan, with breathing and with any motion, really feeling high confidence you're in that lesion. And that's called cone beam CT scan. So that can be integrated with it. So that's kind of all the hottest technology, and it's evolving. And I think this is really helping in getting diagnoses and proper diagnoses earlier and doing things with greater safety. I think I'll just stop there and just summarize that really the biggest points I wanted to make is I can't talk about this stuff without prevention and tobacco cessation. Early nodule diagnosis and staging is critical, and high risk may drive decisions to treat patients immediately, kind of the early stuff, the what and the why, and the staging is incredibly important in all this. But the decision to biopsy as opposed to repeat do serial imaging in moderate risk nodules is really important, and often pulmonologist and patient pulmonologist decision making that's sometimes done with a tumor board. And really our greatest tools are in very central masses to diagnose lung cancer using the PET scan, the bronchoscope with and without ultrasound, and in peripheral nodules, we can use this navigation technology, also with ultrasound to get us in the right spot, or still transthoracic needle aspirations to help get a diagnosis. So all these cool tools are fun and improving, but above all, the decision-making that goes into it is really key. And I can't stress that enough. I think I'll stop there and stop sharing there and take any questions.
Great, Dr. Fuster, that was amazing. Thank you very much for that update. That really took it from the beginning all the way to the latest cutting edge. And we're going to be joined in a second by the other members of the mission committee in a panel discussion. Dr. Snyder will be here, and Dr. Akuthota, Dr. Wong, and then Captain Lowry will be joining us as well. But while we're waiting for them to join us, I do have a starting question, which is the data that are commonly quoted about the safety and the benefits of lung cancer screening were based on people that had their screening probably about 15 years ago, right? Isn't that about when it started?
Yeah.
And we commonly quote the complication rates versus the number of people saved by having that scan based on that stuff from like the early 2000s. And but the easy question, I guess, is have the risks and benefits changed? Is it way more beneficial because the treatment and the diagnostic things are better? And is it way less risky because now we have all the cool toys that you just showed us?
Yeah, and in fact, I can give some hard numbers of the past to confirm what you just said, which is right, that those numbers are around 3 lives saved for every 1,000 patients screened and about 3 major complications that could happen. So that's the kind of balance sheet that I think Dr. Monarchion was talking about. And when you think of that rule of threes, it is something from, as you correctly pointed out, more than 10 years ago. Now I'm telling you how these kind of biopsy techniques can be done with great accuracy, but also with lower risk, and having some of those major complications in patients that are fragile, have COPD, have interstitial lung disease, have the kind of things that can make stuff risky anyway, have gotten much better. And I would just venture to say that these things like Navigate, Veritas, these studies are giving us the numbers of complication rates with the accuracy. And we can't recreate the whole lung screening trial with that right now, but I'll bet if we would have numbers like 3 lives saved per 1,000 or more as time goes here, with lower complication rates, 1 to 2% or less. And so that whole balance sheet makes a better shared decision making, and making it more of a grade B to a B+ or an A- recommendation to screen nowadays. So that'd be my 2 cents on that. Other questions though?
I'll ask another question while the rest of the panelists are getting ready. I'm wondering about what do you think is the biggest impediment to lives saved from early cancer detection? Is it people just not getting screened? Is it the screening technique isn't good enough, or the diagnostic tests, improving or something? I mean, where's the biggest opportunity to save lives?
I think there's the two biggest ones, the real back to, you got to go way to the beginning on this one. And the elephant in the room was really what a lot of this does the minute you start increasing the number of people that have the discussion of lung cancer screening, even the discussion, is there's a smoking cessation discussion that can save more lives than screening, believe it or not. And that was learned very early in the terms of the impact and the course of the trial as it was going on. The other side is exactly I'd say more your first concern than your second, which is just the getting it out there in our, in the number of eligible people that are folks that are eligible to be screened, actually still kind of is way higher, and then actual screening rates still pale state by state. And in California, we're kind of doing kind of in the middle, I would say. There's some East Coast states that screen just more than us and are up in the 10 or 15 or 20% of eligible people that can be screened. And there's some states that are down in the 1%, 2%, 3%. And they're not only insurance reasons, it's just getting the whole thing out there. Most states approve the insurance. And I'd say that's a bigger elephant, or a bigger problem to be up there with smoking cessation, as just the technology. And once you have a shared decision making to actually get it done, I think that the serial steps and the downstream procedures and all that are relatively smaller, but they're still correct concerns, as you said.
I was wondering about the impact that maybe we as a committee could have on both of those things, on smoking cessation and encouragement of lung cancer screening, maneuvers by health fairs and that sort of thing. Once we start doing that sort of thing again,
Yeah, before I joined these kind of things in the ALA and saw what the ALA was doing in the last 10 years or 15 years, just the chance to be able to get the word out and have venues for this throughout the country, city by city and community effort by community effort. If it's lung expos, if it's walks, if it's whatever, that's where sometimes we can make more of the noise, or just simply missions to get it out there that go hand in hand with cessation. And so that's all going a lot better now, I think. But go ahead. Yeah. Dr. Akuthoda.
Yeah, Mark, thanks. Nice talk.
Thanks.
I wanted to ask you why, this is just your speculation, why you think lung cancer screening is not quite as much on people's minds as something like a colonoscopy, or why, what it is. These are the things we're going to do about making it more on the top of people's minds. But why is it different?
Your point right there could shake mortality more than any of what I just said today. Because if you just can increase that by 5% in a community, the impact can be huge. And I think it's hard to say, some of it comes from the thing that grabs me when you tell somebody and they just never knew it, that actually lung cancer is the leading cause of cancer death. People would just, they would just guess things where your doctor talks to you about a blood test, fecal occult blood test for colon cancer. Your doctor talks to you about whatever, mammography, or your doctor they're all important. They all have a certain efficacy that's quite good in terms of number needed to screen to be, and there's a screening technology, but it's the information that I'm not sure if it has to do with stigmas or the inability to talk about it enough in a community. These are all possible theories that have to do with smoking in a population that is at risk, that deserves screening and care just like anybody else that would be screened. And so there's something in terms of our historical blockade to get things out on this. And when you even bring up lung cancer as a leading cause of cancer death, it's not well enough appreciated in the community. There's something about sticking needles far in the chest and these kind of procedures. I said, if I have a nodule, it's a death sentence, I could die, and maybe the procedures I go through can be horrific, but part of these kind of discussions are demystifying it and making it, talking about how we can still safely approach things either through serial CAT scans and their low dose and all this stuff that does take education and takes, more than 5 minutes, but less than half an hour, maybe, to get out to a lot of people, and so it's kind of a combination of things, but I don't have the accurate answer to your question, and it's excellent, and it's what we want to promote an understanding of in our community, but I kind of did my best with it.
Yeah, thanks. That was great.
Yeah, I think Mark too, just to add to what you're saying, I mean, they're all true. I mean, I remember like when they did, remember those pink little ribbon buttons that they
Right.
pinned for breast
Right.
cancer? And then the one that they came out for lung cancer was
I know.
because it was, unseen, but yeah, but no one knew you were wearing it, right? 'Cause
Right. You're right.
right. So it was just nuts. But the blame factor, and I think too, people, I think, have a hard time. Just it's our human nature, right? We have a hard time gauging risk. And people think chest CT, like you were talking about, and they think, oh my God, it's just radiation, right? And so there's that. But then, with breast cancer and colon cancer screening, it's already built into our system, like it's
Yeah.
partly automated. If you show up and you're a woman, you're something age, I mean, boom, the thing comes up, and so you're reminded, because I know, just to be fair to our primary care colleagues, I mean, there's so much that they're already screening for, right?
Yeah.
And why
Yeah.
can't we make this? I mean, even now when you're ordering a low-dose chest CT, you have to input the information twice. Once while you're ordering,
Mhm.
and then the second time, at least in UCSD and Epic, before you can sign the order, it comes up with another
Yeah.
like algorithm, and then you have to put in all the same numbers, how many you're smoking.
Mhm.
And at some point you just go, oh God, I can't remember. And then you just give up. And then, I'll do it next time. And so, there's these system barriers too that make it hard for people. And I think just having reminders, because the other thing I see is once you've had one, right, you're supposed to keep having them. And so the reminder should just come up automatically.
And lung cancer, your points are all excellent, and it should make it easy for people, and through a tobacco use, a reminder to pop up. We're actually working on better ways than that in the VA right now, just how you get pinged on it, and that makes it more equitable, because you're not just picking and choosing patients across a system. But the other thing you helped me remember in your discussion, which was good, is lung cancer is really the most recent new kid on the block. So it came later than breast cancer screening or colon cancer screening. And so when it was relatively new, we were really pounding it hard in terms of, well, show us evidence and show us, and it, grade C, maybe B, and it got pounded so hard, even though these early mortality benefit was there. It's just that all the concerns about complications and procedures and risk to benefit and shared decision making went so long that it's just making its way to like push the ranks up some more, which is tough because it's the leading cause of cancer death. So.
Yeah. I remember when ATS, the first clinician guide they came out with was supposed to make it easy, one of those, plastic cards.
Right.
It was pages long.
Right.
So many, if then this, and I just think we put up to a lot of barriers.
Mm-hmm. Yeah, we got to make that easier. Yeah, thank you.
And I wonder whether some of those barriers, like I said, were based on data from so many years ago. And, I think it'd be pretty fascinating to even just show on a talk like this, what a CAT scan looked like 15 years ago and what a CAT scan looks like now. Where a CAT scan 15 years ago, getting a 1 millimeter size slice was really
right.
State-of-the-art technology. Usually they're about 3 millimeter slices, and now we're about 1/10 as small of a slice. So it's almost like a magnifier glass, 10 times what was available 15 years ago. And all of those estimates that we had about who should get these scans and all was based on these nodules that were big enough to see on these really old style scans. And I'm a little bit worried about us not keeping up with that technology,
Right. And rehashing data now the way it stands in this day and age with the number needed to treat and the risks for the procedures and that stem from all that with added technology.
Mark, could you reiterate what your recommendation is for screening of a low risk population? So an adult who's never smoked, never been a household of smokers, has never had occupational exposure, What's the routine screening that should be done for that?
That's a great question. So believe it or not, probably the best data I've seen for that is locale dependent on the globe. So interestingly, there is a lot more of that type of a patient in Japan or in Asia, where you might have a never smoker, but just a family history or and it's the type of lung cancer that a different group of people get and a different population than a more heavily smoking population that has a different genetics. And so many lung cancers are more represented in Asian female non-smokers than American female non-smokers, way more, to the point that than in our country, if you did the same type of technology on an annual basis, let's just low dose screen everybody past 50 years old, without, regardless of tobacco, regardless of making any other decisions about it. Probably at that point, when you start talking about your pickup rate for real cancer compared to complications of 1 or 2% and not 3%, let's say, and just extra radiation in the younger people, for example, the 50-year-olds, the biologic risk just from even low dose radiation is still there, but it's low. That's why we use low dose. But your downsides might start to exceed your benefits of simply picking it up, because your pickup rate would be so much lower. In a different population, there is literature from not our mainline literature from the United States, but in a lot of the lung cancer journal literature and screening, there's actually a few papers that talk about reasonable thresholds with family histories and not smoking histories in other parts of the world that show that low dose CT screening can fit with what we call these category 2. Category 1 is randomized evidence, that we actually randomized chest X-ray to CT in a smoking population. We don't have as big of a database in those other populations, but there's enough kind of categorical sort of level 2 risk, meaning just what were the outcomes on small studies and non-randomized studies in those populations, and just the pickup rate in having a family history or certain occupational exposures. And you could build a little tree for like 1 or 2 of these with low tobacco risk or secondhand tobacco risk, which is not insignificant. Those would be the kinds of things that I would say might have yield in certain parts of the world. They're just not big enough here to routinely do risk to benefit. So you might have more downsides from sticking needles in or doing even the better technology stuff in our people now with that. Does that kind of make sense?
Yeah, thanks.
Mark, Phil in his talk last week had talked about how these people who met the lung cancer screening criteria could get scans, and then some people that had maybe a higher risk of lung cancer sort of could not. And I'm wondering about everybody's really experience with what happens when we do lung cancer screening and make that sort of order on somebody who doesn't fall into that, fixed written category. Do they not get approved? Does insurance say no? Does a radiologist say no? Or what happens if you're trying to use your own judgment?
Yeah, great question. And in fact, what Phil was illustrating, I think, in something I've actually used in certain groups to teach about is really, it's really calculator risk. So there's actually kind of these sort of fancy math or Bayesian statistics of your pretest probability and different exposures, different groups. It comes from more data than just simply, for example, a smoking threshold, although a lot does come from that, and your age and maybe a family history. There's actually newer ones with asbestos exposures built in. And then they do allow you to input into those calculators your race, for example. But what he was contrasting at the time was saying someone's 48 years old and not 50 and doesn't make the screening criterion of 50 to 80 and 20 pack years, which is our current criterion. And yet they're 48 and has a much higher chance of getting lung cancer in 6 years through one of these calculators than someone who's 52 and meets the criteria and just falls at a much lower risk because their total exposure rate of tobacco is less. There, you can imagine there's no fine line. That's your point, is that you have a gradient, and it's absolutely right. And I think that's where, and a little bit on was brought up on disparities, that we have higher rates of lung cancer in certain racial groups, as much as, he was showing examples of how Blacks versus Hispanics versus whites can have different risks. And so those are built into these calculators actually. And they're actually a reasonable way of knowing that someone who's not quite screening age, would still be at high risk. And so we haven't made a uniform move to use risk calculators, but if that comes up to a practitioner, it's something that takes the individual practitioner's judgment with that patient to say, you have enough other risks and you can make the decision. And in most our centers will allow a screen at a 48-year-old with has a high family risk and asbestos and a tobacco threshold that's just under 20 pack years. So those individual things we've have mechanisms for with e-consults and things like that in the VA to allow for it in those situations. So it's practitioner dependent.
Well, Mark, it's happened again that our discussion was just so great. I could sit here and do it for hours. But I'm afraid we're going to have
apologize.
To, but thank you very much, Mark. That was really a fascinating talk. Thank you to all the panelists and those of you who have given these talks over the past several seasons. It's been a delight to host them, and it's been really fascinating for me. So thanks everybody for tuning in. Thanks for listening on YouTube. We'll see you guys later.
Thank you so much, everybody.
Bye-bye.
Thanks, Tim.